Thank you for a little bit of time today. It doesn't need to take too long. So first, I'll just have you just introduce yourself, introduce Vista Community Clinic. Where are you? What do you do? That sort of stuff.
Okay, so Sue Ann Park. I am a pediatrician, but also the director of clinical informatics at Vista Community Clinic. We're an FQHC in North County, San Diego, but we also have satellite offices, one in Lake Elsinore, which is Riverside County, and one in La Habra, which is Orange County. We have about 67,000 plus patients assigned to us. In 2020, trying to make sure our dates are right, but the governor appointed a first Surgeon General for California, and she happened to be a pediatrician who was very involved in ACEs, which is that adverse childhood experiences, and knowing that that affected particularly the FQ world, our patients and the problems and SDOH hurdles that they have. And so she wanted to reimburse FQHCs in California to screen for ACEs. So the ACEs Aware project was started, and clinicians have to be trained. So as part of our onboarding, all clinicians are trained who are going to see kids and adults, because it goes up to 65. And the challenge was we wanted to make sure that we screen for ACEs. In kids, it's every year until the age of 21. And then older than that, up to 65, it's once in a lifetime. So we didn't want to overbill. We wanted to make sure that we only did it once a year, and our kids we see often throughout the year, especially in the first 2 years of life. So potentially we could be double billing, which we didn't want to do. And then we wanted to also not burden the clinician to go over the ACEs if they didn't need to, if it was already addressed, in a previous visit. So that was our challenge. And at the time, Nextgen did not have an ACEs screening
Perfect. And
tool
let me
in the
just let me
screening
just pause
tools.
you right there. So ACEs, for those that may not know, is adverse childhood experiences, so trauma in childhood. All right.
Yes,
Thank you.
yes. So we created our own using the template editor, and I don't know all the background specifics of it. That's where our IT folks come in, but they were able to not only give us a red warning in our assessment plan that ACEs was due. It also, when we did we made an acknowledgement in our screening template that the clinician acknowledged it. It pulled in the score. It also pulled in a diagnosis code, and we found a generic diagnosis code for screening. And if the score was higher than 1, it changed it to problems within the childhood or some kind of other generic screening tool that let us know that the ACEs wasn't 0, that the adverse childhood experiences score was not 0. And then we knew we had to, maybe tailor our anticipatory guidance with that patient. We had handouts entered into our document library that were recommended by the ACEs Aware state program that California instituted, and it's some great resources on what ACEs are, what kind of things you can do in it as a pediatrician, the kind of bonding you would want for mother, child, parent, child to support healthy childhood. And that is what we created. Took a few turns to make sure that the triggers were correct. We also wanted it to gray out at a certain after 65 to make sure that you couldn't even click on the ACEs survey, because we weren't going to even reimburse for that or get reimbursement for that. So those are kind of the things that we did.
That's perfect. So, the background of needing to incorporate a new assessment tool, right, in Nextgen is one that is fairly common. But I know that Vista has done this sort of thing, before, and you're pretty good at it. So, I mean, how did you approach it, kind of like as a project? Like, who did you bring together? How did you gather the requirements for the change that you wanted to make? Like, how did that process kind of work?
So we wanted a clinician champion, so we brought in the pediatric director because the majority of the ACEs are done in childhood, and we brought in the MIS director and one of her template builders, and we saw the potential. We knew that the reimbursement would be significant, especially in that first year, because it was brand new. We had over 67,000 patients. I'm gonna get the number of how many patients of those 67 are under 65, but it's a significant amount of money that we knew was coming.
Yep.
And I think our planning meetings were prior to COVID, so we were actually having sit down meetings face to face, looking at the potential that this was. And as an FQHC, we're always looking for funding
Sure.
to help with our other programs that support our patients. So that was the team we got together, and then they started developing, and we started meeting, I think, every week or every other week just to see how the template was going, making sure we had a good workflow, testing it, making sure. And then we also brought in finance once we started building, once the template was pretty much done and we were testing it, we wanted to make sure finance billing on the back end was seeing the charge not once, not more than once, but an appropriate amount of time. And that seemed to work pretty well. I mean, other than the little glitches we had initially, once we started going, they were really pleased with that, and they felt that um, it was working well. We also needed HR to be involved only because clinicians had to be certified. They had to have submitted their certification that they were trained, and we had to make sure that HR was keeping that up also so that we weren't falsely claiming reimbursement if the clinician was not trained. And it took some time also to really get all the clinicians on board to get trained. And we also just started talking about trauma-informed care. How does an FQHC, do that in a busy schedule? And we had some clinician meetings where we had guest speakers come and just talk about trauma-informed care. So, a benefit of this whole process, other than, of course, the monetary reimbursement, was just everyone thinking in a trauma-informed way,
Yeah.
which is great for our patients. Yeah.
Yeah, no, I love it. Love it. When you rolled it out, did you roll it out for every location, every clinician, or do you remember how that worked?
I feel like we probably focused on pediatrics first,
Hmm.
just because obviously it impacted us the most, and worked there. And we have a pediatric only clinic, and then our off sites have maybe one pediatrician on site. So it was kind of a slow rollout that way. And then it's always hard to fit it in into family practice because they have very complicated patients. So we rolled it out slowly to them. And luckily, it was really once in a lifetime for their patients up to the age of 65. So it was a lot easier. And, frankly, our what was interesting was our clinicians knew their patients so well, they would get the ACEs score and it would be 0. They're like, that is totally wrong. Let's do this again. We know you're not being truthful because I
Yeah.
know what happened. We've talked about what happened to you in the past. So it was a really good conversation
Mm.
between patient and clinician on the adult side. And really, we did not have any pushback. It was a little bit challenging in OB-GYN. That was something kind of new for them to talk about ACEs with their patients. And then for behavioral health, um, they were basically getting the referrals, and so they knew that we were doing ACEs, and we would refer a lot of our patients for therapy.
Hmm.
And it was just common in the reason for referral, high ACE score, of 6, 10, whatever. And so they got well versed pretty quickly that we were, and they're obviously the referrals went up pretty rapidly. Coupled with COVID, it was kind of a double whammy
Yeah.
for the behavioral health team, but they did great. They're doing great with our patients.
Well, that's terrific. So you may not have it in front of you, but I have it sitting here. Your entry to the contest. Are you comfortable with me sharing the patient numbers that you?
Sure.
Yeah. you said you have 67,000 patients total. It's probably now, but your entry, you screened just over 35,000 patients in the first year, which is 2020, which is doubly impressive because I don't even know how many of those patients you saw in person during that year. And then almost as many in 2021, and then about half that in 2022, 15,000 or so. So that's
Yeah, and I don't have the current numbers, but a significant amount of patients getting screened.
yeah, that's amazing. And then quite a bit of revenue to the health center as well. So that's awesome.
Mhm.
All right. So as I said, you can see the experience and the expertise and the way you bring this together. You make sure all the departments are involved. You make sure BH is ready to catch all these referrals. That finance is making sure the charges are going through. So there's a lot of lessons for people maybe that are newer to this game. But what advice would you have for someone who's trying to apply for a grant, trying to meet a challenge in their clinical care? How should they get started? How should they think about it?
I mean, I think it's important to get the right people at the table. Definitely have an executive buy-in person, and we did. We had invited our director of clinical programs. So because a lot of and the ACEs and the SDOACEs, the social determinants of health project, those kind of coincide. And what do our patients need after you just? It's always a problem. You ask the questions. Now, what do you do with the answers, right? So once you know that there is a need, we need to hook them up with resources, and that's why the executive we brought on was the programs director, and she, that's what her team does. They help find resources for our patients. So get the right people at the table, know what your goal is, um, you know, check in often. It needs to be a lot of our projects now we meet weekly until we really get going, and then we wean it down to monthly until we're really solid before we stop meeting. So, and we still meet. I mean, it's been 2-3 years. We're still meeting ACEs, but not as often. Monthly or quarterly, I think is where we're kind of going because it's just so stable now and streamlined. We just recently had to make sure some of the new hires were getting trained properly, that kind of thing. But other than that, it's kind of a machine that's running on its own now. So that's good.
Awesome. Well, I love it. So thank you for what you're doing for CHCs, and thanks you for being part of a CHC. Any other final thoughts for our audience here?
No, just happy to be able to give you some insight into what we do.
Great. Thank you, Dr. Park. Have a
All
great
right.
day. Thanks.
Bye.
Thanks for your time. Bye bye.